Okay, thank you very much. With this greeting, I am pleased to welcome all of you who are participating, whether in person or online, in this international conference sponsored by the Pontifical Academy for Lyme, Palliative Care, an international laboratory. Our work starts today and will continue tomorrow and Friday, February 10th and 11th. I offer the Academy special thanks to the Professor Christoph Ostgathe, President of the European Association of Palliative Care, an organization that is a leader not only in Europe, but also around the world with respect to the scientific aspects of palliative care, as well as in effective clinical practice, and that has always devoted special attention to the ethical and the spiritual dimensions of care for the dying and for all who are gravely ill, as well as their families. Having Professor Ostgathe with us in Rome will certainly make the work of our conference more fruitful and will be of great benefit for the Pontifical Academy for Life. Indeed, our Academy, which is a Holy See entity, has been concentrating for several years on end-of-life ethical issues, especially with a view to the promotion and wide acceptance of palliative care about the world. In palliative care, we have a very scientific, ethical, and cultural model for the accompaniment of those who have reached the end of their earthly journey. The palliative care movement is not only an understanding way to be close to those who suffer, it is also sends a message about how to understand human existence. It offers a very specific way of living together that focuses on the person and his good, which is the goal not only of the individual, but of all society. Palliative care is truly a right, and we can be pleased that awareness of this right is growing little by little, but at the heart of this right is a recognition that each of us is part of the community, a member of our coexisting humanity. This vision has produced new thinking in medicine that has led to a rediscovery of medicine's true vocation, which is caring. We all know that healing is the principal concern of medicine today, but we must avoid believing that it is the only goal, cost what it costs. Rather, we must remember that there are limits to our existence that cannot be overcome. The illusion for earthly mortality, which is what leads to believing that a cure at any cost is the goal, is misleading. Recognition of our radical human finitude lets us reject obstinate continuation of treatments that inflict useless suffering or even result in further harm. Pope Francis recalled this idea this morning at the general audience, stating that, I quote, "We cannot avoid that, and precisely for this reason, after having done all that is humanly possible to cure the sick person, therapeutic overskill is immoral. Reducing or suspending treatments that are no longer proportionate is not the same as abandoning a patient. Even when nothing can be done to cure a patient, it is not true that doing nothing is acceptable. The patient must be accompanied with love, with relief of pain, with support as his or she grows weaker, respecting and maintaining the patient's dignity and rejecting alternatives that destroy that dignity, such as assisted suicide or euthanasia. We must be careful, the Pope said today, not to confuse this help with unacceptable drifts that lead to killing. We must accompany to death, but not provoke death or help any form of suicide. This is a quotation of the Pope, the last sentence. Allowing for death on demand means surrendering to a philosophy of abandonment and exclusion. Instead, we must provide for appropriate accompaniment in the face of negative physical developments and the inevitable questions about the meaning of suffering. This includes not only the patient, but also his or her family and caregivers. By launching the Palliative project in 2017, the Pontifical Academy for Life committed itself to serious consideration of the human and the social challenges that a patient's fragility and advanced illnesses present to all of us today. In this task, the Academy has become a scientific and cultural partner for the palliative care medical community, which is deeply committed to its task with professional skill and compassion. In 2018, as part of its Palliative project, the Academy sponsored an important international conference which resulted in the publication in several languages of the White Book for Palliative Care, which is addressed to all stakeholders having a role in the development of palliative care. In more recent years, numerous other international study initiatives has been conducted in India, the United States, Latin America, Qatar, and several European countries and others are being organized. I spoke with someone of Spain or Portugal, in New York too. I think it is absolutely necessary to spread this kind of initiatives. It's a cultural problem, not only medical clinical problem. The COVID pandemic may have diverted attention from these and other issues, but our duty is to continue on the path leading to the accompaniment of all those who need palliative care, including COVID patients. These last have not always been provided with the palliative care they need. We are aware that despite a positive trend in the acceptance of palliative care around the world, there are still many barriers that hinder access to such care or limit its quality. Encouraged by the international community, we have decided to follow up on the work begun in 2017. We will study different strategies and models in order to overcome the difficulties that prevent palliative care from reaching the patients who need it, and in order to lend support to families, all within the framework of existing and proposed laws and theoretical models. The barriers and obstacles to delivery of palliative care are likely to be similar across national boundaries. Thus, the example of Italy can be a useful laboratory within an international perspective. Countries that are more successful can offer models and strategies that the countries that are just beginning can use to their advantage. In this context, I suggest that the watchwords of our conference should be concreteness. We must strive to find solutions that actually work. And secondly, responsibility. We must offer proposals that respect the dignity of the people we serve. In this work, I have been assisted by very well qualified experts. Some are members of the Academy, others are not, but all have scientific distinction and ethical credibility. I would like to thank the following persons in particular: Professor Carlos Centeno, Professor of Palliative Care at University of Navarra in Spain, Dr. Gianlorenzo Scarabozzi, President of Palliative Care and the Pain Therapy Section in the Technical Scientific Committee of the Italian Ministry of Health, Dr. Maria Donata Bellentani of the Health Planning Directorate in the Italian Ministry of Health, Dr. Adriana Turriziani, former director of the Villa Speranza Hospice of the Catholic University of the Sacred Heart for Rome. Let me conclude this greeting with the words of Pope Francis, certain that prophetically they were also meant for you as participants in this international conference. I quote, "I appreciate your scientific and cultural commitment to ensuring that palliative care can reach all those who need it. This type of assistance has no less value for the fact that it does not save lives. Palliative care accomplishes something equally as important as the same of lives. It values the person. I urge all those who in various capacities are engaged in palliative care to fulfill your commitment while maintaining a spirit of service and remembering that medical knowledge can be called true science in its noblest meaning only if it works for the good humanity, a good task, a good that is never opposed to life and human dignity." Final, the word of Pope. This is the humanistic root that animates all our work. I am sure that we will work together effectively and learn much from each other. I wish each of you a very profitable 3 days together. Thank you very much for your patience.
Dear Archbishop Monsignor Paglia, dear experts here in the room and online, and I've seen there are more than 100 people online already, or maybe even more by now. 138, very good. As the president of the EAPC, I am very proud and thankful that I have the opportunity to speak to you today as part of the welcoming ceremony of this important international event. Thank you so much for the invitation. The EAPC, as you have said, is a federation of 54 national palliative and hospice societies from 33 European and now also from non-European countries, with approximately 60,000 associate and individual members from a total of 52 countries worldwide. So the scope of the EAPC is not only Europe, it's a global scope. It brings together many who work in hospice and palliative care, both full-time and, very important, also on a voluntary basis. The EAPC respects diversity and sees itself as an international platform to promote quality hospice and palliative care for all ages, from premature and newborn babies to the very old, and that through education and training of those working in the field and, as you have said it, Archbishop, the public. Also through research, advocacy, and evidence-based practice. Under our motto, One Voice, One Vision, EAPC aims to help prevent and reduce unnecessary suffering where it occurs for people with life-threatening illnesses and their families worldwide, and to help to ensure that everyone, wherever they live in the world, has equitable access to hospice and palliative care services as an integral part of the healthcare systems. That this is not, has been achieved by now. We will hear later a little bit more on that. On a systems level, palliative care is both. It's a true story of success, and it is, to be honest, at the same time currently strongly in crisis. When we look back to the first initiatives for a modern hospice and palliative care approach starting from the 1960s, we can be humbly proud of what has been achieved. In many countries, like in Germany, palliative care is an essential part of the healthcare systems, and patients have a legal right to receive good palliative care. Doctors, nurses, psychologists, physiotherapists, social workers, spiritual carers, and others are well trained, and in many countries, palliative care has reached universities. We have professors, we have a lot of research and evidence that is strongly evolving, just to name a very few aspects of this successful development. At the same time, we have to acknowledge, and this is the first area of which I state, and it will be 3 areas, I have to state that palliative care is currently in crisis. The first area is that globally, with 86% of the vast majority of people with palliative care needs, they do not receive or inadequately receive access to palliative care and high quality end-of-life care. This shortcoming includes also the access to opioids. I am sure we will hear and discuss more about that in detail in the next 2 days. The second area in which I say palliative care is currently in a crisis is that we see that in a growing number of countries worldwide, assisted dying becomes by legislation and by High Court ruling a growing normal part of societies and healthcare. Looking in these countries with a longer history of legalizing assisted dying, it becomes more and more evident that in all these countries, its criteria have successively expanded over time. 6 years ago, in 2016, the EAPC stated in its white paper on euthanasia and physician-assisted suicide that the EAPC respects the individual choices for euthanasia and physician-assisted suicide, but stresses the importance of refocusing attention onto the responsibility of all societies to provide care for their older, dying, and vulnerable citizens. A major component in achieving this is the establishment of palliative care within the mainstream healthcare systems of all countries, supported by appropriate finance, education, and research. And you may remember that I said that in most countries, palliative care is majorly under-evolved. For the EAPC, it is, and it will be clear, that euthanasia is not part of palliative care. The answer to the question, however, what national regulations and what High Court ruling on assisted dying may mean for our services may differ from team to team, from expert to expert. Yet, we as Palliative Care Association's services expert cannot bury our heads in the sand like an ostrich bird. The regulations are or will be reality. We, as experts in palliative care, we as a movement, as an approach, have to find a way of dealing with the situation in our countries without betraying the palliative care principles. In Germany, for example, my home country, we expect, after High Court ruling, a new law on physician-assisted suicide in the next 1 to 2 years. And palliative care is and must be an important part within this discourse. The German Palliative Care Association has stated that suicidal wishes should always be met with professionalism and compassion, in the sense of, if you want to die and it's clinically relevant, it's an everyday situation that we have contact to patients that want to die. If you want to die, it touches me as a person, and I want to stand by you as a human being. A regulation, and this is clear, for example, for Germany on assisted suicide, can only be created if suicide prevention is also comprehensively strengthened. And I'm very sure that palliative care is part of suicide prevention, since it can effectively counteract the wish to die in many cases by alleviating suffering, taking a holistic view of patients and their relatives, and improving quality of life. For the EAPC, actively performing assisted suicide is not the task of hospice and palliative care, and we remain convinced that the expansion of organized assisted suicide poses a particular threat to self-determination, especially for the sick, weak, and dependent. As relevant societal structures, associations, the churches, political parties, other groups, we have to find a position in this discourse, weighing our principles against the inevitable, keeping the people we care for with all their needs in mind. I guess also around these conflicting issues, we will have time to discuss here. And the last, you also named it, the third critical area is that, from my perspective, at least partially, the partial invisibility of palliative care in the reaction of our healthcare systems to the pandemic. All our healthcare systems were majorly overwhelmed by the sheer numbers of patients, often outweighing the resources. For this, as Lukas Radput, in a very readable article in The Lancet, wrote it in 22, for this tsunami of suffering, palliative care would have been, and from my perspective is, an important pillar of the reaction of the system. However, starting from a bundle of narratives, I read with a lot of interest, Carlos, your publication on the situation in your service, and with an increasing body of evidence by the time being, there's a lot of studies out there that show that very often the benefits of palliative and end-of-life care in the pandemic were neglected. I know of many wards in my country and in other countries that were, just to name an example, were closed down or significantly reduced in personnel to shift the staffing resources from there to the emergency or intensive care units. Quoting the also very readable, very current Lancet report on the value of death, in the pandemic, people have died the ultimate medicalized death, often alone, but for massed staff in hospitals and intensive care units, unable to communicate with family except electronically. This situation, and we have to bear that in mind, has further fueled the fear of death, reinforcing the idea of healthcare services as the custodian of death. I want to make completely clear that I'm really grateful for the wonderful work that has been and has been done in intensive care by the teams, by individuals. But, and that is the lesson that we have to learn, that every pandemic has also a palliative care side of the matter. For this, we, as services and our healthcare systems were not prepared. And that has to be overcome in the next years. In this sense, I wish us a successful meeting. I would also like to combine this with my thanks to the Pontifical Academy for Life, who invited you and us and took up a very current and important issues for palliative care in the future. And I can say that the EAPC will stand at your side here. This and our work together in the future may foster that we overcome these crises. Every crisis is also a chance. So let's go for that. Have a great day. Thank you.
Thank you, Excellence Monsignor Paglia, for your words, and thank you, Professor Ostgathe, for this wonderful overview of the scope of discussion which we should have to go this way to go during these 2 days. And you have said that the pandemic has to be connected to the essential work of palliative care. And this refers to the UN 2030 goals, where they have agreed upon that every human being on this wonderful globe should get access to appropriate and due care. And we know from studies, if people have the chance to choose, they would prefer adequate palliative care before getting high-tech medicine anywhere in the life. And that is our task to go there. And we learned as well through the pandemic that this pandemic is more a syndemic, that in situation where social systems are fragile and they have been struck by the pandemic, the situation has got worse than before. And so we have to broaden our scope to look at different regions in the world. And we will start with the ingenious people from Africa, because we can learn a lot of them. And it's a pleasure to me to introduce Dr. Emmanuel Luyirika. He is Executive Director of the African Palliative Care Association in Uganda. And he will be connected to us online. And we are happy to have you here. Please start with your presentation. I'd like to see him.
Good day, everybody. Dr. Emmanuel Luyirika from the African Palliative Care Association, and I'm presenting palliative care development and delivery in Africa. The African Palliative Care Association was started in 2003 and is headquartered in Kampala, Uganda. Our vision is access to palliative care and comprehensive chronic care for all in Africa. And our mission is to ensure palliative care is understood and integrated in health systems at all levels to reduce pain and suffering across Africa. My presentation is a summary of steps, innovations, and actions by the African Palliative Care Association, Ministries of Health, and partners in developing and sustaining palliative care services in the context of the COVID-19 pandemic. Before COVID-19, Africa was slowly moving towards improving palliative care services. There were significant developments in East and Southern Africa, and 9 countries had standalone palliative care policies. Palliative care integration into health systems was also taking shape in several countries, including Malawi, Uganda, Zimbabwe, Botswana, South Africa, Kenya, Eswatini, Rwanda, and a number of others. Free access to oral morphine, which is a cornerstone for pain control, was also available in Seychelles, Uganda, Malawi, and a few other places. However, at that time, less than 15% of those in need got palliative care, less than a quarter of the countries in Africa had palliative care policies, as we've seen, and there was a lack of palliative care financing from national budgets. There were few palliative care training facilities or institutions, and the current ones then were in South Africa, Uganda, Malawi, and Kenya, and a few others. There were very few palliative care trained human resources. Palliative care service delivery was largely driven by non-profit hospices, faith-based organizations, and NGOs. A number of countries lacked palliative care in their national health indicators framework. There was limited access to opioids as part of the essential medicines package in palliative care. And there was also a challenge of access to radiotherapy as a palliative care modality, especially for cancer patients, as well as other technologies that are needed in the context of palliative care. Close to 25 countries were regarded as not having any radiotherapy on the continent. In addition, there was a serious lack of access to patient user devices and comprehensive rehabilitation in the health systems that patients with palliative care needs could benefit from. The emergence of the COVID-19 pandemic has complicated but not brought down the services. As COVID-19 emerged, health communication infrastructure and health communication packages were not ready for the challenge. Hospices and other palliative care providers were not prepared to handle highly infectious patients. Hospitals and ICUs were not ready to provide palliative care in the isolated environment. Home care programs were curtailed because of the lockdowns and the travel restrictions that were instituted by several countries. Patients faced severe isolation and shortages both at home and in health facilities. As the African Palliative Care Association, working together with our partners at King's College London, we conducted a survey to assess how COVID-19 would affect these services at operational level. APCA also responded to the communication demands posed by the pandemic, and at the membership level, APCA assessed how they would be affected financially and at operational level. A study was done on preparedness of African palliative care services to respond to the COVID-19 pandemic through a rapid assessment which was done in April 2020. The objectives were to evaluate the preparedness and capacity of African palliative care services to respond to the COVID-19 pandemic. It was conducted through a cross-section online survey guided by the 2005 International Health Regulations and went out to 116 African Palliative Care Association membership institutions and partners. And then descriptive analyses were done. 83 participants from 21 countries completed the survey. 63% had at least one procedure for the case management of COVID-19 or another infectious disease. Respondents reported concerns over accessing running water, soap, disinfectant products at 43, 42, and 59% respectively, and had security concerns for themselves or their staff at 52%. We realized that these items were very essential in the response to prevent COVID, and yet you had these respondents having serious concerns about accessing them. 41% did not have any or make available additional personal protection equipment. 80% reported having the capacity to use technology instead of face-to-face appointments. 52% reported having palliative care protocols for symptom management and psychological support that could be shared with non-specialist staff in other healthcare settings. That highlights the situation that obtained. Furthermore, many hospices resorted to telemedicine where the technology existed, but we know that access to data is still quite costly, so that was a limitation, even outside the study that I've just mentioned to you. Lockdowns that were instituted resulted into limited access to services for non-COVID-19 conditions. Many COVID-19 and non-COVID-19 patients died in isolation without access to palliative care. The use of border borders or motorbikes was adopted by many of the providers to be able to deliver medicines and other requirements to the patients who were at home. That, of course, added costs to the running of the programs on the part of the hospices. I can take some examples from South Africa, and at the time of the pandemic, over 150,000 patients were getting palliative care from the hospices. But we know that over that period, close to 14 hospices closed due to the financial impact of COVID-19. And that is despite the increasing demand. In Kenya, we worked with our partners there to pilot the UHC package for inclusion, the palliative care package for inclusion in universal health coverage. And that was done as the epidemic was breaking out. The other thing that happened during the COVID-19 pandemic, or as the pandemic raged, was that luckily Kenya and Nigeria launched their palliative care policies. But we know that in Kenya and other countries during the lockdown, fewer patients were able to access some of the services such as oncology and palliative care due to the fear and the restrictions, as I've said before. Despite those challenges, other projects like the City Cancer Challenge in Kumasi, Ghana, that Africa is involved in on the technical side for palliative care, was implemented, and a lot could happen during that time when the pandemic was raging. In addition, we were not stopped to support the Democratic Republic of Congo, which is in Group 3A within the global rankings, according to the recent Global Palliative Care Atlas. With funding from the Belgian government and through United Nations Office on Drug and Crime, APCA has been supporting DRC to improve access to controlled medicines. And that has involved trips to DRC to look at what is on the ground, meeting the stakeholders, working out what needed to be done, and then drafting guidelines for use of controlled medicines, and also running training and mentorship programs for the teams from 10 hospitals and Ministry of Health in the DRC. The work also involved identifying a facility where oral morphine reconstitution could happen in the pharmacy lab at the University of Kinshasa. After that, in October 2021, a team from the Ministry of Health in DRC, as well as University of Kinshasa and civil society, visited Uganda to benchmark on access to controlled medicines, morphine reconstitution, and exchanging ideas with the team at the Ministry of Health in Uganda, the National Medical Stores, Hospice Africa Uganda, and meeting other stakeholders involved in provision of palliative care and cancer services, including the Uganda Cancer Institute. That has been supported also by an online monthly mentorship of Ministry of Health and 10 hospitals that I mentioned before. And that mentorship is still going on even into this financial year. And we thank the ECHO team for providing us the platform on which it runs, as well as the team from ECHO India that is supporting us to implement that project. Training programs continued at Chinsantu Hospital in Equator Province in DRC, and follow-up training and mentorship, as I mentioned before, are still continuing. And we are working with the team in DRC to identify the support and funding that is needed to set up the morphine production unit in their country. Let me now talk about palliative care funding during the COVID-19 pandemic. Many governments in Africa diverted funds for cancer and HIV and other conditions that are common in Africa to fight the pandemic. That led to unbearable situations for some of the patients. In addition, lockdowns disrupted access to palliative care and other medicines because of the restrictions on travel and accessing patients' homes. In addition, funding access to care during the lockdowns was minimal, and that again affected especially the non-government sector and hospices that depend on donor money to run their programs. However, some of the NGO funders, like the True Colors Trust, the Open Society Foundations, the Open Society Initiative for Eastern Africa, allowed hospices and hospitals to repackage projects to meet emerging needs due to COVID-19 pandemic and the control measures that were recommended by government. And that flexibility has helped hospices and other palliative care providers to meet the needs as they emerged. I need now to talk about some of the challenges that we faced in COVID-19 in Africa. And main among these is misinformation that emerged. This COVID-19 misinformation increased vulnerability of our patients who are in for cancer, HIV, and other conditions. And it highlights the need for information packages for patients and the public in the languages they understand. This has not been practiced in many countries to have information packaged in all the major languages. However, with COVID-19, it is important that countries start to look at that. There was also increased anti-science stance among some of the people, and that compromised trust of patients in evidence-based approaches. It's sad that some of these anti-science stances and misinformation often came from places that were previously trusted, like churches and some of the health workers. So APCA invested in ongoing COVID-19 webinars to reduce misinformation. Very early on, we also prioritized working remotely, developed, shared through the communications department, evidence-based advisories for ministries of health in Africa, and patient and family and health work COVID-19 prevention tools. In addition, we developed public service announcements that were translated into several local languages and were shared with our partners so that they could run them in their countries. We also developed and disseminated jingles for use on FM radio stations in the various countries. And that helped to equip our partners with some of the information responses that they needed. The assessment that was done that I talked about earlier helped us to assess the emerging needs and how they could be responded to in the future. The other developments that happened during this time is the hybrid methods of accessing patients, where we had telehealth and telemedicine by some of our member hospices and hospitals. We were also able to respond by delivering capacity building programs online, and also developed country level and institutional level capacity building projects, which have also been delivered. As I talked about the activities in the Democratic Republic of Congo as an example, we continue to engage them even as the lockdowns are waning, and we hope that the model we developed for DRC will be very useful for us to use in other Francophone countries. The over 20 COVID-19 webinars that we've run have also taught us on how to tap from expertise, especially in the diaspora, to bring them to engage with the African practitioners and patients. We continue to offer the sub-grants that have given some source of money for the hospices and palliative care implementers. And we thank the True Colors Trust and other funders who have supported us on that. As the COVID-19 vaccines became available, APCA worked to ensure that its members and health workers developed confidence to get the jabs. And to that end, we've developed a video that promotes and encourages people to get their jab, and a link is provided to that. So in conclusion, Africa was already lagging behind other continents in palliative care development. The Eastern and Southern Africa regions had better coverage and access in terms of policy, service delivery, access to medicines, and human resources. The emergence of COVID-19 called for quick readjustments and innovations to continue meeting the palliative care needs of patients, and APCA and partners have progressively and successfully done that. As a way forward, we would like to call upon governments and palliative care providers to invest in and embrace technology and innovation to build resilient systems to overcome contemporary palliative care challenges. Palliative care must also be integrated in all other disciplines, such as intensive and critical care, as COVID-19 has necessitated. In Africa, more support is needed across the board, but especially in West Africa, Lusophone and Francophone countries, so that they can be at par with the Eastern and Southern African countries. Thank you very much.
Well, thank you very much for your very complete presentation. I think you told us of some limits, but also of a huge effort to improve, also with the innovative technologies, the presence of palliative care in Africa. And I think this afternoon is very well built, because in the first part, we have a quantitative look how much palliative care is there all around the world, and is the systematic palliative care network performed, and has people can meet a palliative care network. So the first part is quantitative, and the second part will be more a focus on what kind of palliative care. So after Africa, we are going to USA, and Professor Kathleen Benton, that is President and CEO of the Savannah Hospice in Georgia, USA. Please, Kathleen.
Hello to everyone all over the world. My name is Dr. Kathleen Benton. I am the President and CEO of Hospice Savannah. I am also by trade a bioethicist and have a doctorate in public health. So oftentimes when speaking about palliative care, I like to really dig in and look at the overlap between population health, palliative care, and the quality metrics, and what are the ethical concerns that get intertwined into those. And because of that, you're going to see that theme resonate throughout the art of palliative care here in the United States. I have served as the Director of Ethics and Palliative Care at St. Joseph's Candler for over a decade prior to this position, and published multiple books, all focusing on dignity and end-of-life palliative care. That's my professional background, but I always and oftentimes say that what makes my experience most pertinent to any audience who I am able to engage with is in fact my role as Daniel's sister. Daniel was my brother of 30 years. He was born with the same disease as the Elephant Man. He had 110 surgeries throughout his life and thousands of hospitalizations. He was, throughout his entire life, the picture of a true palliative patient. He oftentimes suffered through pain and symptom issues. He much of the time suffered emotionally, though he had a very joyful life, and taught me the art of and the wonder of medicine, of advancing clinical technologies and how to embrace those, and how to live life through chronic and then terminal illness. He ultimately died under palliative care, not hospice care, because he had a trach and a peg and a peritoneal dialysis. Therefore, it was too many aggressive measures in the United States to make him appropriate for hospice care. And thus, it was an excellent example to me of somebody who could die under palliative care and die well under palliative care. Though in the United States, we try to utilize palliative care farther upstream of hospice. There are many barriers and challenges that we face today, and much of these come out of the pandemic, both the continuum of the pandemic as it continues its bell curve of ups and downs, and the aftermath of the beginning of the pandemic and all that we faced in isolation. In our skilled nursing facilities, which house many, many millions of elderly patients across the United States, there is a chronic isolation that came out of the pandemic. There was such fear that contamination and contagion would occur that these vulnerable people were kept in their rooms for months and months with no visitation from family and no interaction with one another. There's such a vulnerability that came with that because many suffered from dementia, and that kind of isolation advanced the dementia. Many of those in skilled nursing facilities were taken home with family members who no longer wished to see them experience that isolation. And the aftermath in that situation came with great caregiver burnout, as we've seen more caregivers in the United States who are engaging in the vocation of caregiving. And much of the time that is alongside their day-to-day job or occupation. Many Americans do not retire until quite late in life, and thus they are burning the candle at both ends, figuratively and literally, trying to take care of a demented or chronically ill elderly loved one. The continued COVID hospital admissions are still very present. We go through waves just like everyone else. But right now, the hospital that my particular palliative program practices in has about 90 patients in a 600-bed facility, all with COVID. And a great number of those, at least a quarter, are on our palliative service. These three situations or issues have resulted in a high demand for palliative care. Necessary palliative care in the skilled nursing facilities or SNFs, but not necessarily a welcomed demand for palliative care because there's still limitations on who can access the skilled nursing facilities as they try to keep those populations very isolated. There's a major demand for more palliative care at home as a result of all this. The hospitals drastically need to keep patients out of a readmission, especially chronically and terminally ill, who will just be readmitted to be readmitted again. and the hospitals are full of such sick people that the home is a necessary place to have these artful goals of care conversation and to access symptom management. There is a true need to be able to work through issues that may occur in the middle of the night. Seldom do we have any physicians or physicians services who answer call in the middle of the night. And this is very difficult for those homebound patients. In hospitals, the demand is very high simply because the COVID census is high. And when you have a COVID census, you don't know the outcome of the disease. It is a very unknown progression. So starting those conversations early have become very, very helpful. And the palliative service is called on often. There's continued bureaucracy and challenges to making palliative care fruitful. Patients want hospice, but they cannot have it as early as needed because there's still the necessity for the 6-month prognosis. Therefore, palliative care oftentimes takes the place of hospice care. And while it can't offer regular home care services, it gives that symptom control and artful conversation that is necessary for the family. Palliative care teams are often asked by hospital administrators to shorten the length of stay to try to prevent these admissions, but there's no way to affect and impact the outcome if there's not enough palliative staff. And there continues to be a large shortage, particularly with palliative physicians in the United States. With COVID, spiritual care is an absolute must. We're finding that patients really need to find that closure and purpose, and oftentimes have to find it quite quickly, as they did not expect the disease to progress so quickly. We still have half vaccination rates throughout the country. So though those who are vaccinated are having a better outcome with COVID, others are still having a very devastating outcome and need to access conversation and discussion around ventilators and DNR. There are so many patients that the COVID must get palliative because, as I said before, oftentimes they don't know the progression of what that disease will be. So to start the conversation is very, very important. As you can imagine, providers in the past and now still have issue and barriers against those skillful clinical conversations about end of life. It is not necessarily the natural for clinicians. Running a code is sometimes easier than bringing up end of life. Thus, the palliative care team is called on more often. Now that we're in a situation where there's less rapport, where masks are on and PPE is readily used, that gap in trust and conversation, the door is closing even further, especially for other clinicians who did not have this inclination or skill in the past. Our average palliative census right now is ranging from 30 to 50 patients on average. And there is a real new mentality that we've seen that's been very interesting regarding palliative care. When I started this job 3 years ago as CEO and worked with the hospitals to advance our palliative team within the hospital. We're a community-based program working for the hospital. There was some resistance over seeing certain patients with comorbidities such as congestive heart failure or COPD. It's very interesting how COVID has brought a sicker population to the hospital, and there is a new mentality of openness for the specialty. There is a high demand. There is not resistance. When a palliative consult is put in, there used to be a barrier to have this discussion and what is it going to look like and should we really bring them in this early? That resistance is just not present anymore. They welcome the help. The burnout is apparent, and where there used to be a guarded nature against palliative coming in, that is just not as active as it once was. The taboo is lost. We have to continue to face the fact in the United States that palliative is a cost avoider, not a function of revenue production. And that still is a continued issue. The codes are now there. We obviously use, and many know, a coding and billing system in the United States, many other countries similarly. The difference is that where a cardiologist or a pulmonologist may be able to see 50 patients in a day or 30 patients in a day, a palliative physician can average in the hospital between 7 and 10 because the conversations are so lengthy and so laborious. Symptom control takes understanding the pain, not just assessing the physical. And the art of conversation takes those hours. Payers, fortunately, such as our commercial payers and Medicare and others, are starting to see the need for this serious illness management. And thus, instead of paying based on a code for an hour's worth of conversation, there is discussion about payers taking on a per member per month continuum, where a palliative unit would be paid a fee per month to manage the patient at home. These are serious illness programs that are being discussed readily and actually demonstrated in pilot studies across the United States. It's a hard look at how palliative care can actually act as the case manager, manage that patient, have those discussions, manage the symptoms, and be that 2 a.m. call instead of an emergency department visit. It's very much like a hospice model, but it allows for upstream care before that 6-month prognosis. We're still seeing the same issues that come with low advocacy. Everyone's in PPE, there's no relationship building, limited numbers of family members are allowed into the hospital. Healthcare has become more sterile, if you can imagine that, and the inability to have compassion, to relate, to focus is coupled with strong burnout of clinicians. The continuity is lost because of this. And with no ability to fully control all the symptoms of particularly COVID, there's a different approach and a little bit of a morale lost in the entire specialty for the clinicians involved. As we look at our vision and growth for our model, we are really looking at earlier interventions, utilizing home health screening tools. So where that rehabilitation takes place, it's also an artful discussion and a control of symptoms. We can only have that impact if we start the conversation much earlier. And now that others are open to that, we're trying to hone in on that allowance. We want to own the continuum. We want to case manage those patients. We want to be in the homes and observe the barriers, observe the family dynamics. And that is what our model is looking to do with physician, nurse practitioners, social workers, and chaplains that are in the hospital, also pivoting and following the patient home. And that is our goal for the coming years, to be able to do that through telemedicine and through expansion of our full-time employment by support of the hospital, who will send that patient home and will work to avoid the readmission. I think overall, the overarching futuristic vision of where palliative in the United States was years ago, though it was never optional, it was always the right thing to do for patients in their absolute best interest. It may be seen or have been seen by others as an optional specialty, because a physician may feel that he or she could do it themselves, or rather they may feel that the patient wasn't ready and was not at that trajectory of disease to have that conversation and have that specialty. It is now a high demand necessity. The patients see the need. They want regular support. They want someone to address their symptoms. The physicians are burnt out. The clinicians across the board are burnt out. They want any extra support, especially when it comes to communication in a world where we're somewhat disengaged and disconnected. And they want that interdisciplinary approach that the palliative specialty brings to the team. So I believe that in the United States in particular, we are challenged to continue to come up with models that are fruitful and that allow us to, at very least, break even. And thus, I feel that the future of these per member per month and case managing and starting earlier down the road of conversation is the hopeful solution. It is predicted that it will be hospice care that will engage and go further upstream and engage in this case management early, so that when the patient is ready for hospice, they're also able to access hospice earlier. Whereas in the past, though you can have the 6-month trajectory, many patients only receive good quality hospice care the last month to weeks of life, or even days or hours. If we are following them upstream in the home and the rapport is built and the trust is there, then it will be a very streamlined and smooth continuum for palliative care to become hospice care. I look forward to your questions and our discussion, and thank you for taking time to listen to me.
Thank you, Dr. Benton, for this very interesting and demanding talk. And I think we will have to discuss a lot of questions, but the organizers made plans to have the discussion after the 3 talks. So we do have to proceed, but I would like to remind the audience here and the international audience online that they should write down your questions in the chat, and Dr. Tolona, I think, will collect them so that we can answer it and discuss your comments and your questions in the general discussion after the 3rd talk now. And it's a pleasure for me to introduce Professor Carlos Centeno from Navarra, who is very experienced in palliative care. He's also a member of the European Association of Palliative Care, and he will report on the situation in Europe. Welcome.
Thank you for the introduction. Thank you for everyone to be there. Some of you at home and other here in the, okay, this is for the slide. Thank you. So, okay, I need to see the slides in the full screen, if possible. Can you actionate the full screen? Okay, and now can I see? Okay, we are preparing the, okay, I will use my computer to see my screen. I think that will be better. So, as I want to present about the situation of palliative care in Europe, I'm going to try to give a broader vision, not only in the last years, but trying to see the situation in Europe from in the distance, a broad vision, an overview of the situation of palliative care in Europe. But because I'm going to give you some data, graphics, some map, I would like to start in different way to talk about a patient that I have seen in the last days, in the last weeks, in fact. That patient was living in another country, in a border country, neighbor country of Spain. That patient was living outside Spain, but was receiving proper care in the University of Navarra hospital. The patient has strong metastasis in the sciaticus, that is the main nerve of the leg. Because that he was very painful with neuropathic pain, very difficult to relieve. We tried several course of medication with different combination, using adjuvant, using opioids, but finally we decided to use methadone. Methadone is another opioid that can have some benefit for this neuropathic pain. So we did it, we switched to methadone, and suddenly the pain was very well controlled, in better control than in the last weeks. So because that, in 2 days, the patient was relieved, the patient decided to come back to his country. So I connect with his country, with a palliative care physician that I know very well, and explain the situation, the clinical situation. But she told me that in her country has not methadone, so the patient will be a big problem. And there, that we did then was to connect with our pharmacy, and the person that in the pharmacy is trying to arrange things directly from one pharmacy to the other pharmacy, doing the prescription in Spain and sending the medication to this neighbor country. What we learn from this case? I think that we can learn that palliative care is about people, and about people that has extreme suffering sometimes pain, sometimes other symptoms, and behind is a serious illness usually. We can learn here that palliative care is about collaboration, team working, a multidisciplinary team is in the essence of palliative care. Also, we can learn that palliative care can be done for many people, but sometimes palliative care also needs some kind of specialization of a kind of a special medicine. So palliative care can be done for many, but sometimes it needs also a specialist. And also we can learn that palliative care in Europe is still in development, because this is happening in Spain and in neighbor country. Next slide, please. Oh, I have, okay. The data and the figures that I'm going to use are from the European Association for Palliative Care, from the Atlas, the last Atlas of Palliative Care in Europe. But also I'm going to use unofficial information from the World Health Organization that is in the last year developed this nice graphic, are in Russian and in English available in the web page of the World Health Organization. All this information was elaborated in the Atlantis Global Observatory of Palliative Care at the University of Navarra, where I'm working. So the last information about palliative care in Europe. World Health Organization stated at the beginning with the definition of palliative care, or putting some emphasis in the definition of palliative care. The first sentence emphasized that palliative care is a special care for people with life-threatening illness and their families. My first remark is people is using different names, and some people is using recently the word serious illness and not the word life-threatening illness. And this is because trying to be not so linked with the death, because palliative care is not because the death is there. Palliative care is because the people is in severe suffering. In that way, we can emphasize a little bit this issue. Also, in the statement of the WHO, we can see that the spiritual care is there. The WHO is talking about spiritual suffering. So spiritual care is mandatory in palliative care for the international institutions too. Other remark that the organization is giving in Europe is benefits the health system, save money. Palliative care save money. It's a question of social justice here. To spend money at the end of life in wrong things, in technification of the death, or sometimes is needed, but many times it's not needed. Many times we need personal well training and not the hospital or technification. So palliative care benefits health system. And finally, we have now that something that looks like new in the palliative care field, empower people and communities. The WHO is telling us that palliative care has to be done for many health professionals, but also from volunteers. All people can work in palliative care. So this social aspect on palliative care is in some way new in the field. After that, the question is, palliative care is for who? For everyone who needs it. That was the words of the Pope Francis to this audience today, no? And this is telling by the WHO too. So palliative care is for the entire disease trajectory. My colleague from the United States emphasized the need of early intervention of palliative care. Here in Europe, this idea of the early intervention is pretty new. Only some hospitals, only some oncologists, only some palliative care teams, despite the evidence that is behind, is using this approach, this early intervention of palliative care. This is a pity, but this is a reality. Also, the statement of WHO is telling us that palliative care is for all countries. And happen in Europe that we have two Europes, in fact. We have a very well palliative care developed Europe, that is the west of Europe, and a very less developed palliative care Europe, that is the east of Europe. So 2 Europes, 2 worlds. Palliative care is not only for the rich countries, but for all the countries. And if you look at the figure, you can see children, because this reminds to us that palliative care is not only for adults, but will be also for children. And we will talk about that later. Palliative care is not only for cancer. We have in Europe, 2 years ago, 4.4 million of people in need of palliative care. And in the next 2030, we will have 5 million of people in need of palliative care. But only half of them has cancer, less than a half, around 40% of them. And 1 or 3 has cardiovascular diseases, and 1 of 4, more or less, has dementia. So palliative care is for several diseases that are in need of this kind of support or control. Are we ready for the challenge? The answer is not univocal, but we have several answers. The first answer is about the availability of services. The European Association of Palliative Care very recently confirmed that the number of services that we can estimate right for a population is 2 services per 100,000 of population. That means 1 hospital palliative care team and 1 home care team. This is the magic number, 2 services per 100,000 inhabitants. What we have an average in Europe, 0.8, so a little less than the half. So 65% of the population of Europe has not access to palliative care. And at the European level, many countries has not a specialization for physicians working in palliative care. And that is worse even, 83 of the European countries do not teach palliative care to all future doctors. In the map, we can see the challenge. We can see the 2 Europe. 1 Europe with morphine and 1 other Europe without morphine. 1 Europe with fully adequate access to morphine and the other half without this adequate level. In this other map, we can see the level of the services. Remember the number 2 as the ideal number. Okay? we can see in Spain 0.6 services per 100,000. In dark blue, we can see countries like United Kingdom, Ireland, Belgium, the Nordic countries that has more or less close to the magic number 2. But many other countries, like Spain, has less than 1 services, 0.6, and many other countries in the east part of Europe, we have almost no service per 100,000 of inhabitants. So inequities between countries in Europe. Look at the bars. In the bars, you can see in orange and red the things in hospitals. Remember that the good balance is 1 team in hospital and 1 team in home care. That we are seeing is that some countries has this good balance, Italy, for instance, but other countries like France has not this balance. So we can look also at that palliative care is needed in the place where the patient is, and many times the patient is at home. Thank you. For the next slide. Talking about inequities, we have inequities also inside the countries, and you can see here inequities in Spain. In Spain, we have the Mediterranean coast with more level of services per population. You can go to the beach there and you can get palliative care. But inside the country, we have places like Andalusia with 0.4. And at the north, we have other countries, other regions, like my region, with 0.6. So inequities, low level of palliative care development in Spain, and inequities between countries, between regions too. And despite this low provision of palliative care, we have a law of euthanasia. Many people is asking in the country, why is that? How is possible that a country that don't provide palliative care for the people provide euthanasia? The article is from one palliative care physician, but many people in Spain is asking the same questions. And here we have a good news. If you walk between Piazza del Popolo to Piazza España, you can find this building with this big announcement of a new hospice for children, Bambino Gesù Hospice for Children, that will be built in this magnificent building in the center of Rome. And in the map from the Atlas, you can see that in almost all West countries, we are developing more and more palliative care service for children. This is a good news. And in the column, you can see on the right, the countries where the team of the Atlas identified perinatal palliative care for children that are recently was born. So this is a good news also for palliative care. The approach that we are using in palliative care is useful for these people, for these little boys and girls that was born hours or minutes ago, or even was not born, because it's palliative care with the mother and with the father of the children. A good news. Barriers. We can talk all the afternoon about barriers, but I only say something about the impossible prescription. Impossible prescription in some countries where you can only prescribe a few amount of morphine, and in other countries you can prescribe only a few days of morphine. In other countries is available, but many European countries, that was very well studied in the European Association for Palliative Care years ago. And to me, one of the biggest problems is that the future health professionals are not taught about palliative care. Universities are not teaching palliative care. I think that is a main barrier. Students love palliative care, as you can see here. This picture was taken last week in my university with the white coat, palliative care physician in training, teaching to the students of the last year of medicine, teaching how to approach a palliative care patient. And look at the faces of the students, very interesting discussing that issues. And in the graphic, you can see the situation in Europe. In blue, the countries that are teaching palliative care for all. Only 10 countries, Germany, France, the more advanced United Kingdom, the more advanced countries are teaching palliative care for all. But in most of the countries, palliative care is only offered as an option in several other courses, or palliative care is not teaching more than a half of the university. A real pity. About the specialization, the good news is that in the recent years, specialization was approved in many countries. It's not the case of Spain. And so I am in sorrow for that. What countries can do? Countries can do policies. Some of the countries choose to do laws, and these are palliative care laws that was approved. Italy approved his law in 2010. Germany approved his law in 2015, a way to promote palliative care from the government. Palliative care can do also education, and in Europe, the Erasmus institution is promoting palliative care education. Last week, start here in Rome, a new project that is called EAPC, that means hope, about e-learning palliative care, trying to fill the gap that there are in the university without professor, without placing the curriculum, without hours of time in the curriculum, and so on. And countries can do also promote primary health care, try to incentivize primary health care, providing palliative care in the primary health care centers and at home. This is things that can be done. And every country has to evaluate palliative care. This is the last framework that WHO recommend to the countries where the services are at the top, are the ceiling, is the roof of the house of palliative care, but other things, other dimensions are needed. In the background, the society promoting palliative care, and WHO developing indicators to measure that dimension. In the background also, the health policies that are supporting the building. And in the floor, the research. We need evidence-based, and there are indicators for research. To sustain the roof, we need medicines, but we need also good professionals, very well training. My message to home is Europe represents the more advanced palliative care available in the world, but global palliative care needs the European experience and direction of Europe. Palliative medicine has to be taught to all future professionals, and university has to be congruent with the need of the health system and the people. The Academy of Life has an important role in the palliative care advocacy. We have here in front the white book for global palliative care advocacy that is translated in many languages from the Academy of Life. These are advanced and positive solutions for the challenge of the today's society. Thank you very much.
Yes, thank you very much, Professor Centeno. Many topics, I would have some questions, but I see that questions are arriving, and I think we the speaker can choose how to answer. For instance, the first question is the numbers about America Latina. I don't know who is the right speaker, if you or Dr. Benton. And the second one is something about music therapy to Dr. Benton. If I mean, if there is a space for music therapy in palliative care for Dr. Benton, if she has experience and the spiritual dimension. And so we can answer to the first two questions. And please, Carlos, about America Latina.
Carlos, do you want me to, okay, I'll answer the spiritual question first. I can't turn on my video. Can the host turn on my video? I think I'm not allowed to do that. Is someone able to start that?
You can.
I can't. The host has not allowed me to do that. So I'll speak without my video, but I think the host has put they have to start the video for me. But anyway, regarding spiritual care, in my program, we work with the hospital directly, and we have a joint venture where we utilize their chaplain, or we have in the past. These chaplains are not your regular chaplain. They actually have palliative care certification. So right now we're looking to grow that. We work with a local chaplaincy program and encourage and teach the chaplains coming out of that program to access the certification for palliative care, which is a internet-based certification. I think the experience is truly where they get more of their professional wisdom, but it does help. It does help to begin. Oh, there I am. Sorry. To begin with this particular certification. Most importantly, just to have spirituality recognized in your IDT, even if it isn't someone who's been trained and palliative certified. I think the voice of a different discipline in that interdisciplinary team meeting to remind the other disciplines that particular purpose and closure must be accounted for. And at times, in particular in hospice care, where the chaplain is a part of that interdisciplinary team, I can tell you that oftentimes we cannot take care of the clinical or physiological pain because it is actually more spiritual or emotional. And it necessitates a chaplain or a spiritual advocate to come in and have this conversation with the patient so that we then realize that whatever kind of medicine or medical management that we are doing is not working because we are treating the wrong kind of pain.
Because there are other questions. However, before giving to Carlos for South America, Professor Sahm, I think, have to integrate something to this answer.
I can't hear.
Okay, I like your comment on that, but I'm a moderator, but I would like to put in some comment on that because I'm from the city in Germany with the highest percentage of migrants in Germany. And we have discussed end-of-life care from the hospice groups together with directors from several mosques we have in our city. And they said, we would not like you to start end-of-life talk and look for our patients. They wouldn't like that. They said, you should not start it. This is an interesting experience. And my question is to all the speakers, if you have got any similar experience with respect to multicultural backgrounds.
I'm sorry, I'll just add as an ethicist, I experience that all the time, that the religious affiliation or that particular culture, however it was tied, wanted to own that area itself and not have us do the same. And so certainly you have to be very sensitive to that. And that is part of the expertise, frankly, of a chaplain, when to know what to do and when to know when to do nothing. However, I'm obviously speaking specifically to patients who are asking for this help. So that there's two different cases, but absolutely I've had that same experience.
Thank you very much.
Okay, so to put together two kinds of questions for Professor Centeno. One was about facts and figures in South America, and there are at least two questions about education. They ask, okay.
My first answer is from the colleague from Latin America. If you go to Google and put Atlas of Palliative Care in Latin America, you can find a very nice edition that was published 1 year ago, was produced by the Association of Palliative Care of Latin America and the University of Navarra. You can find easily by Google because it's for free for anyone. The other two questions about education, one is how we can know that the education is not well integrated in the universities. It's a very interesting question because someone can think that it's evident that it's not integrated, but we have some evidence in addition of that. One evidence is that the students are requiring that teaching. The International Association for the Students are telling us and are publishing notes and statements asking palliative care teaching. This is the first evidence. The second evidence is published. There is a ranking of palliative care universities in Europe, elaborated by a group of the European Association for Palliative Care, and is already published in a journal. But also in the last edition of the Atlas of Palliative Care in Europe, you can find that after to search in the country by country how many universities has mandatory courses or optional courses or transversal courses about palliative care, we cannot find more than 10 countries teaching palliative care for all. But even more, if you count the number of chairs or professors of palliative care in countries, you cannot find many. In my country, you can find 2 professors of palliative care, and in other countries, you cannot find even more than 3 or 4. So that's our evidence. The last question is how many hours are recommended. I would recommend to go to the European Association for Palliative Care that has published recommendation for undergraduate teaching. And there is recommended at least 3 European credits, European ECTs. That means around 75 hours of work, usually around 25 or 30 hours of work, of teaching.
Thank you very much. I saw a question for Dr. Luyirika, and more or less the question was, you told that African hospices were not so ready for infectious epidemic of COVID-19, but was it surprising because in Africa infectious diseases were present before? So what do you think about this?
Thank you very much. Can somebody help me to open my video because I cannot open my video to be visible. But having said that, yes, that's a very good question and a very important question. Initially, when palliative care was introduced in Africa, the focus was on cancer. When HIV came, some of the hospices were scared of caring for people with HIV. And then it became clear that they also needed to care for patients with TB and multi-drug resistant TB. And all those have proved that it's possible to integrate infectious diseases into palliative care and within the context of hospices. Now, initially, the governments also thought that COVID-19 was for closed hospital settings, for ICUs, but the numbers that have happened over time and the effects that have persisted even after going through the initial phase of the infection demonstrate the importance of us who are involved in palliative care, all the stakeholders, educational institutions, and those who offer in-service training and education, and the people who fund hospices to put aside time to equip the hospices, the staff in hospices, on the aspect of infectious diseases, even the very infectious diseases like Ebola and COVID-19. The challenge that comes up now is the issue of increased funds that are required to buy the protective wear that is required and creating the environment where that care can be supported, or how hospice and palliative care providers can get into places where these are cared for. Yes, it's tough, but I think it's the time now for us to prepare our hospice and palliative care teams within Africa and other places to interact with infectious diseases are managed, so that we don't let the severe isolation and loneliness that goes with what we saw in the COVID-19 situation. So it wasn't very surprising, but we know what is missing and we know what we need to do to improve the situation. Thank you very much.
Thank you. And we have another question. I think it's directed to all the speakers. Looking forward, what practices, trends, and innovations do you hope to see in the field of palliative care? And I think we will lay down this question to all the speakers. What are the recent trends? Where will we go? And what will be reasonable to achieve? Professor Centeno.
Only one word, because when the counselor look at me, I know that I have to be very short. My word is integration, more integration of palliative care in oncology, more integration in cardiology, more integration at primary care. Integration, only one word.
And Dr. Benton?
Yes, I likewise, I agree with Carlos and would just back by saying I saw a question that I'm going to weave this into. In the United States, hospice is underutilized. Hospice is only for patients who physicians can say have a 6-month or less prognosis. And that's a very difficult question to gauge. And as a result, it is seen as a service that can help people when they are imminently dying. Hospice has a lot more services with it because it has home care and nursing assistants who give baths in the home, social workers who come to the home. Palliative care in the United States is more of a medical model. It's led by the physician. It's interdisciplinary, certainly like hospice, but there are not services in the home that really help the caregivers take some of the load off the caregivers by regular bathing, regular assistance, and most important, availability all the time, because someone who is chronically and terminally ill has complex issues which come up in the middle of the night and in non-working hours. And that is not something palliative provides. So what I hope is that the palliative model will start to look more like the United States hospice model, where we are able to come and assist in the home, be available 24/7, and start way further upstream when a chronic illness is realized to be uncurable. and the family really needs help taking care of that patient.
Thank you for this answer. And now, Dr. Luyirika, what is the innovation you will await?
Thank you very much. My key word is investment. Investment in palliative care services right from the home. And that involves embracing technology and innovations that make that easy. Investment in access to palliative care medicines, especially the essential opioids that are not accessible. Investment in human resources for palliative care. Investment in palliative care, into seeing the palliative care policies implemented across countries. Thank you very much.
And I think it goes without saying that this is an appeal to our people living in the rich countries to support this investment. I think that's, now we do have the task to get a coffee break, but I will promise that the speakers will answer questions in the chat as well. They can do it later on, and I will invite you here for the coffee the Academy has provided, and I'm sure that all these people watching us online worldwide will also get a coffee anywhere. Thank you.
Thank you very much.
Kathleen.
Yes, I'm here.
I'm Father Renzo. Thank you.
Hey, Ren. It's good to hear your voice. Oh, you're very welcome. I'm glad to be here. But I won't say I'm disappointed that I'm all the way over here. Next year, we must be in person.
Okay. Thank you again.
Okay. Thank you.
Thanks, all speakers.
Well, we are here. I think we are very good because only 10 minutes of delay is an American way of working. So in the second part of the afternoon, we are going to see what kind of palliative care is suggested to people. And in particular, in those countries that have legalized the medically assisted death. And I would like to say a name. And the name I put here is Cicely Saunders. Are we going to suggest the original palliative care, or are we going to suggest some other kind of palliative care, I mean integral palliative care and so on? This is a question that I put on the table, and I think we in Italy are going to make an association inspired to Cicely Saunders' way of palliative care, and I think it could be a good example. So the first speaker of the afternoon is Professor Chris Gastmans. He is a full professor of medical ethics at the Catholic University of Leuven, and ordinary member of the Pontifical Academy for Life. Professor Gastmans, please. Thank you.
So, good afternoon, ladies and gentlemen. My name is Chris Gastmans. I am Professor of Medical Ethics at the Catholic University of Leuven, and I would like to talk about palliative care in Belgium Belgium, where an Euthanasia Act was approved and came into force since 2002. And I will give some of my experiences with palliative care in a context of a country where euthanasia is allowed. In my presentation, I would say something more about the following topics. First, regarding the foundational anthropology when we talk about end-of-life care. Second, I will say something about the ethical foundation of all medical decisions at the end of life. Third, I will say something about respect for caregivers as moral agents, and also about respect for healthcare institutions as moral communities. And last but not least, I will also say something about the societal challenges and responsibilities that we have regarding palliative care in a context where euthanasia is legal. First, the foundational anthropology of end-of-life care. When we look to the end-of-life debates in our countries, then we see that there is an important emphasis of the value of individual autonomy. Respect for autonomy, and even in its more individualistic interpretation, that means like self-determination, seems to be the founding value when we are talking in a societal context about end of life. Also, the medically assisted death legislation is mostly founded on this individualistic value of autonomy. For instance, what we look when we look to the definition of euthanasia in our own Euthanasia Act in Belgium, then we see that euthanasia is defined as the intentional termination of life of a person at his or her request. So at his or her request represents the autonomous decision of the individual. So what this kind of legislation lacked is incorporating the relational embeddedness of human beings. Everything is focused on the individual, and the relational context of a human person is forgotten. What we should do is not criticizing autonomy as a value, because autonomy is a good value, but what we should do is to criticize the individualistic interpretation of autonomy. As I said here in this quote, there are no relations possible without individuals, but it is also true that there are no individuals possible without relations. What should we do then? Well, we should focus more on another concept of autonomy, and that is the relational autonomy. And the relational autonomy focus more on the relational nature of end-of-life care. In end-of-life care, not only the patient and the doctor is an important component. There is the patient, of course, who has a central position, but there is also the family, the caregivers, society as a whole, etc. And in end-of-life decision-making, all these people involved should go into a dialogue and should try to interpret each other's attitudes, perceptions, informations, etc., in order to come to a joint consensus decision. And this takes time. An end-of-life decision is mostly not a decision that is taken from one moment to another, but it is a decision that grows throughout time. And concrete operationalizations of this relational autonomy model in end-of-life are, for instance, shared decision-making, advanced care planning, and the palliative filter. And now I will go more in detail about this last model, the palliative filter, in the context of euthanasia requests. In the Belgian Euthanasia Act, it is declared that the physician should mention the possibilities offered by palliative care and their consequences to the patient who requests euthanasia. That is the only reference to palliative care in the whole Euthanasia Act that we have in Belgium. But there are some limitations to this statement, because it said the physician mentions. It is not stated that the physician should be an expert in palliative care. Every physician is allowed to inform the patient about palliative care. But what if a physician has no expertise in palliative care? Then there is no guarantee that the patient will be adequately informed about palliative care possibilities. So what we did in a lot of hospitals is to put extra requirements. They are not included in the law, but they are extra requirements that we included in our dealing with euthanasia requests in nursing homes or hospitals. What are these extra requirements? Well, the first one is that not only a physician should inform the patient about palliative care, but it should be a palliative care expert, a palliative care physician who has the right expertise and knowledge to inform the patient in an adequately way. The second requirement that we added is that the physician should not only mention the possibilities of palliative care, the physician, the expert, the palliative care expert should discuss all palliative care options, including palliative sedation. And the third requirement that we added is that all stakeholders in the decision making, so not only the patient and the physician, but the whole team, the family members, should be involved in a process of shared decision making. So this is a very concrete example of how, via relational autonomy, the input of palliative care can be much stronger in the context of dealing with euthanasia requests. Another thing that I would like to mention here is the need for an adequate foundation for all medical decisions at the end of life. I think it is, and that is what I experienced in the last 20 years, there is an urgent need to inform citizens, and that means potential patients, relatives, healthcare professionals, not only about euthanasia, of course, but about all medical decisions at the end of life, and also about their ethical qualifications. I give two examples. First example is withdrawing life-sustaining treatments. Should we continue with cardiopulmonary resuscitation? Should we provide antibiotic treatment? Should we continue with artificial nutrition and hydration in a terminally ill patient at the very end of his life? Well, here it is important that we inform people, the general public, that we will avoid therapeutic obstinacy. Therapeutic obstinacy means that we continue with medical treatments, even if we know that these medical treatments are not effective anymore, more from a clinical point of view, and on the other hand, they are also not meaningful anymore in the life of the patient and the relatives. That is what we should avoid, because people are feared by therapeutic obstinacy. So what we should inform people is that medical interventions should have a therapeutic aim. There should be a therapeutic goal for medical interventions. And that can easily be arranged by the legislation of negative advance directives. And in most countries, we have these kinds of legislation. Second example is the example of pain and the alleviating of pain and other symptoms, so pain relief. Here it is very important that we explain to the general public what palliative sedation means and what is the difference between palliative sedation and euthanasia, but because there is a lot of misunderstanding about the difference between palliative sedation and euthanasia. So what is needed is a lot of education, a lot of training of the general public, potential patients, relatives, but also healthcare professionals about the ethical qualifications of all medical decisions at the end of life. That means also that competent end of life, that means all aspects of palliative care should be available for everyone in society, everyone who is in need of it. And here I give some elements that should be taken into account. That means that palliative care should be an essential part of medical and nursing school curricula, so that future physicians and future nurses are educated into palliative care and what it means and the ethical qualifications. Second, there is an urgent need to continue with more palliative care research in the universities. Third, we need a legal and an ethical framework for palliative care in every country. And in every country, there should also be a broad access to palliative care services in home care, in hospitals, and in nursing homes. I would like to say now something about respect for caregivers as moral agents. And here I refer to the role of consensus objection. And I quote here again our Belgian Euthanasia Act that says that no physician or other person can be compelled to perform euthanasia. So that is a good statement, I think, because that is a legal protection of consensus objections. I think that consensus objections are fully compatible with professional obligations. So they should be respected in a professional way. The moral person of the physician or the nurse should be considered as a rule. A moral person is one identity. And when a person is forced to act against his conscience, then this means that his personal identity is violated, and that should be avoided. So we should respect the consensus objections of healthcare professionals. That's one thing. But on the other hand, we should also agree that this implies some obligations from the healthcare professional. The first obligation is that the doctor should disclose consensus objections to the patient and to his colleagues as soon as possible. That is one thing. And another thing that is, according to me, that there is also an obligation of the physician to provide a continuum of care. And that can also include that the physician collaborates to refer the patient to another physician. I refer here also to the important element of moral distress, because more and more studies are published that makes clear that moral distress in physician is mostly linked to their involvement in end-of-life practices. So that means that when the consensus objections of physicians are not respected, that they develop moral distress. And so when we think that consensus objections should be respected, then this also implies organizational arrangements, because respecting consensus objections can mean that other colleagues should do things that they don't want to do. So I would say here that we should discuss a policy how we can respect consensus objections in a concrete team, in a concrete hospital or nursing home, in order to avoid moral distress. And then I come to the respect for healthcare institutions as moral communities. You can say in a nursing home or in a Catholic hospital, we don't do euthanasia within our walls. We are against euthanasia. That is something that you can do. But this is only a theoretical position. it is not enough. Because when you have a euthanasia act in your country, there will be euthanasia requests in your hospital, even if you are not going to conduct euthanasia. There will be patients who request it. And so you have to deal with these requests in one or another way. And therefore, it's really important to develop written ethics policies on all medical decisions at the end of life. How do we deal with euthanasia requests? What do we mean with written ethics policies? Well, written ethics policies are ethical viewpoints based on shared ethical values and the translation of these viewpoints in clinical ethical procedures. The ethics committee of a hospital or a nursing home could take the lead for the development of such ethics policies in consultation with all relevant stakeholders. And that means also the board of directors who should approve the ethics policies. And when we have an ethics policy, how we deal with all these difficult medical decisions at the end of life, then as a hospital, as a nursing home, we have also the duty to communicate that in a transparent way inside our institution, so that all healthcare professionals in our institution are informed about our ethics policies, but also outside our institution, so that potential patients and relatives are informed about the ethics policies that are followed within a hospital or nursing home. And last but not least, I would conclude now with some societal challenges and responsibilities. What we see is that in more and more countries, euthanasia legislation is improved and comes into force. This has a reason, of course. And I think the reason is that euthanasia legislation corresponds with the current societal conception of a good death. What is the current societal conception of a good death among the general public? Well, I think people think good death is an individualized death. It is the individual, the patient himself or herself, who take the decision how he or she would die. An individualized death, a planned death, a rapid death, and a death without suffering. That are the components of the societal conception of a good death. This is based on an individualistic interpretation of autonomy. And therefore, I think we should criticize it from a relational autonomy approach, as I explained earlier. The second message on a societal level that I would give to you is that when the barrier of legislation is passed, legalization is passed in your country, you should be aware that the practice of euthanasia tends to develop a dynamic on its own in the direction of normalization. Even if you accept in your country a rather strict and limited euthanasia legislation, then you should be aware that as soon as the act has been approved, the legislation, the euthanasia practice will broaden. And that is mostly argumented or justified by the principle of non-discrimination. So when you have a very strict legislation on euthanasia, for instance, only for terminally ill patients, then there will be very fastly requests to broaden euthanasia also for non-terminally ill patients. So that leads to what we call normalization. What is normalization of euthanasia? Well, that death by euthanasia is no longer regarded as an exceptional thing requiring special justification, but the other way around, instead it is regarded as a normal death the standard death. It is a benefit not to be restricted without special justification. So that means that you come in a situation where not euthanasia should be justified, but not doing euthanasia should be justified. And the last message I would like to give you is that you should also be aware that when an act on euthanasia is approved or comes into force, that control of euthanasia practices will not be a priority anymore. In all euthanasia legislation, there is a certain control system. But my experience is, we have that also in Belgium, such a control system. But my experience is that it is not really controlling the practice. And it is also not a priority to develop it in a more adequate way. So my conclusion is that there is a need for a permanent critical voice towards the normalization of euthanasia. And therefore, we should work together. We should not divide ourselves, but we should work together to make this critical voice heard. What can we do? Again, based on some experiences I had in Belgium in the last 20 years, it is important always to criticize and to make public unethical cases. That is the experience that we had in cases of euthanasia for psychiatric patients. By criticizing it and by making this critique public, I had the impression that we could make a point. The second thing is that we should develop a constructive story about the good death without euthanasia that is based on a relational autonomy approach, and that we should make this story known via the media. And that is also a good way to do it. Relational autonomy is a positive concept. So we should give stories about this positive concept of relational autonomy. And my other experience is that healthcare professionals, physicians, nurses, palliative care physicians are in the best position to intervene and to tell these positive stories in the media in an authentic way, because they have the professional experience and they are trusted by the general public. So they are in the best position to tell this positive story in an authentic way. Some years ago, I wrote together with colleagues from UK a book, Euthanasia and Assisted Suicide, Lessons from Belgium. In this book, we described our experiences with the Euthanasia Act. And if you need more reading, then I would recommend this book. Thank you very much for listening, and thank you to the Pontifical Academy for Life for the invitation to give this presentation. Thank you very much.
Thank you, Professor Gastmans, for this very informative talk. And please keep available for the discussion we will have at the end of the three positions. Now, it's a pleasure to introduce Professor Johan Menten, also from Leuven University. He's a radiotherapist. He obviously has a lot to tell about radiotherapy in palliative care, but he will talk about the ethical situation with respect to assisted dying in Belgium, and we will learn more about your situation. It's important for us. We in Germany, the neighborhood country, will get a discussion within the next 1 or 2 years about a new law, and hopefully we can learn from you. The floor is yours.
Thank you very much, Mr. Chairman. Thank the Pontifical Academy for inviting us to give our experience after 20 years that we have handled the Euthanasia Act. Okay, thank you. So I will hit 3 different points. I will tell you something about the law, something how we developed palliative care in Belgium, and finally, what is the effect of the euthanasia law on the physical and how the physicians have to handle that. First, the laws. We see here that in 20 years, several European countries have an active euthanasia law. And especially in the last year, Portugal and Spain joined the Netherlands, Belgium, Luxembourg, and Switzerland. And nowadays, the discussion is going on different countries all over the world. And so we are all struggling with the same problem. We in Belgium had in 2002, at the same time, 3 new Belgian laws. The first one, the law, the Act on the Patient Rights, and that stipulated that all the patients have to be informed about diagnosis and prognosis. So the time that if a cancer was diagnosed, that it were abnormal cells or an infection is finished. The patient has the right to know exactly what's going on, has the right to see everything from the patient file. There is a need for informed consent for both treatment, but also the patient has the right to refuse treatment, even if this is a curative treatment and it is a worse outcome for the patient. Still, the patient has the right to refuse. There was the Act on Palliative Care. We were one of the countries with very early a law on palliative care. And it was said that every patient has the right to receive palliative care. Mobile palliative teams supported the home care. The hospitals and nursing homes had the duty to develop a palliative support team so that every patient on the bed could get advice from an expert palliative team. All over the country, we had 360 beds geographically spread in relation to the density of the inhabitants with palliative care units. And the palliative care units were placed in separate architectonic structures with a minimum of 6 and a maximum of 12 beds. And finally, there was the Act on Euthanasia. And the first sentence of that act is, euthanasia is a crime except when some defined criteria are respected. Palliative care. Expert palliative care is everywhere available. In the home care, in the nursing homes, in the hospitals, palliative care units, and, important, free of charge for the patient. But palliative care is restricted too frequently to terminal care. It is too late in the disease trajectory. And because it is perceived as a terminal care, it is always postponed until the last days, both by the patient, the family, but also by the healthcare professionals. So we have to learn that advanced planning earlier in the disease trajectory is important. A second problem is that communication, both for the patient and the healthcare professionals, is very difficult about advanced care planning, about palliative and terminal care. That's not yet a routine. Healthcare professionals are not educated how to communicate. What are the good words to use in such a dialogue? And it is said already several times today, palliative care is not implemented in the core curriculum of healthcare providers. Although we have the promise now that next year in Leuven, we got palliative care in the core curriculum of the basic education of all the physicians, equally like dermatology and ophthalmology. And it is 2 EC points. It is something, not enough, but it's already something. And of course, we need more clinical palliative research to underpin the clinical practice so that it is more evidence-based, so that we get more credit from our colleagues. Does not react? Okay. We informed the public and the healthcare professionals by textbooks in our own language. where we covered palliative care, how to guide a dying process, and how to guide the family in bereavement. And we actualized every 4 years the book. We make analgesic charts, how to calculate, for instance, the breakthrough medication in accordance to the daily maintenance dose of opioids, because the calculation was something wrong. And we helped the nurses and the physicians how to get better pain control. We constructed booklets in the pocket of all the healthcare professionals, not only for the physical pain, but also for psychosocial and spiritual issues. We learned there how to start for spiritual pain. How can you explore it? Because this is not only something that has to be done by the chaplain, also the nurse, also the physicians, also the psychologists, social workers have to learn how to recognize spiritual needs. Because at the end of life, everybody has spiritual needs. And then we invited the heads of the departments to have in all the wards at least one nurse and one physician who is representative to stimulate palliative care in all the wards. And this is the result. We had a huge recruitment. And in the yellow rectangulars, these are physicians. So we have many physicians, many nurses, social workers, psychologists, chaplains, who take the engagement to stimulate palliative care all over the hospital. And we meet this group 4 or 5 times a year in a lunch meeting where we hit some important things that were practical difficulties in clinical work. But also, if a team was in stress, we went with the palliative team to that team and we give an ad hoc education of 1 or 2 hours. So to promote palliative care all over the hospital. And educated caregivers are present 2 or 3 days in a week in the corridor where a lot of visitors pass to inform them at a very low threshold with information about palliative care and end-of-life decisions. So it was nearly impossible that there was one healthcare provider in our hospital not aware of palliative care. And you see that over the time, in 15 years, the DNR status do not reanimate, but of course the status included much more. It was also the patient is not anymore transferred to the intensive care or will not receive any more antibiotics, or we will not start artificial food and fluid, or there is no indication anymore to go for surgery, and so on. And you see, for instance, 4 weeks before the death, that the numbers are raising from 35 to nearly 60%. Just at the end, we have about 90% of the patients have had a discussion, because in the last week, many patients are no longer cognitive competent to have a dialogue about this. But we see that the numbers are increasing. And you see, and this is important, the more that we were experienced in palliative care, we saw a drop in the patients with refractory symptoms in need for palliative sedation. The palliative sedation frequency dropped from 7 to about 2% in our palliative care unit. So it means that if you give adequate expert palliative care, you see better symptom control and there is less need for palliative sedation. The euthanasia, how to handle an euthanasia act as a Catholic healthcare provider. Well, about 70% of the Belgians support, the healthy Belgians support the euthanasia act. But at the end of life, less than 5% of the advanced terminal patients received a euthanasia procedure. So the thinking between healthy persons and sick persons is totally different. The healthy persons are pressing for having a law. The sick patients are not asking that so frequently. And some Catholic hospitals and care houses were very reluctant to implement the act, but were publicly blamed because they ignored a democratic act. And so over time, the pressure came more and more, and is euthanasia procedure everywhere possible due to the public and media pressure. You can't ignore this pressure. Individual healthcare providers have the possibility, like Chris Gastmans already said, according to the Euthanasia Act, not to be involved, not to actively be involved in a euthanasia procedure. But what happened if a physician who cared for more than 20 years a patient, and the patient is asking, and persistently asking for euthanasia, are you as a physician then free? Question mark. The Euthanasia Act did not change the numbers of palliative sedation in our palliative care unit. But what we see in the last 10 years in the palliative care unit, where we have originally 2% of palliative sedations, the number of palliative sedations is increasing. And where we had in the first 10 years 2% of palliative sedations, we see now between 8 to 11 patients are in need for either palliative sedation or in blue, euthanasia. So it means the 2% is increased to 5%. It means what we see in the public, suffering is no longer accepted. And the threshold to label suffering as a refractory symptom, that threshold is coming down. So there is a change in the public, we think. For the whole hospital, and we are a university hospital of 1,500 beds, and that means that we have about 1,500 deaths in a year, that we saw in the first 10 years of the Euthanasia Act, we had 1% of euthanasias, and it increased to about, 0.5%, and that increased to about 1%. But in the general public, we have 2,500 out of 100,000 deaths in Belgium. And although the advocates of euthanasia said we need a Euthanasia Act to get transparency, it's amazing that the registered euthanasias for 75% are coming from the north, the Dutch-speaking part, and only 25% of the French-speaking. And nobody can explain that. Are the French-speaking persons more palliatively sedated, or the euthanasias not registered? At least I have to say the transparency is not there, like was promised. And we have about 2.5% euthanasias all over the country, while in our hospital it is about 1%. The Hospital Ethical Committee, in collaboration with our palliative care team, advised on top of the legal criteria, like Chris said, every euthanasia request has to be explored by the palliative care team. And one of the questions I saw, is that an obligation? Yes, in our hospital there is an obligation, because the pharmacist will not prepare the lethal drugs if on the prescription there is not a stamp of the palliative team. And the stamp of the palliative team proves that there is a palliative filter, an exploration, and that all the other possibilities of palliative care are at least discussed with the patient. But also every euthanasia request will be discussed in the regular treating and caring team. It is impossible that a doctor and a patient make by two persons a conclusion, while the nursing and the other healthcare providers are looking. They have to understand what is caring. And if everything is done, Is every expertise that is available in the hospital implemented, or is there something that can be done extra and was not yet done? Euthanasia procedures can only be performed in the normal working hours, normal working days, not in the evening, not in the night, not in the weekend, because we think if an euthanasia procedure has to go on, it needs the carefulness of every medical act and the guidance of the team and the guidance of the patient and the guidance of the family. Every euthanasia procedure has to be reported by the treating physician at the head of the department, at the president of the ethical committee, that you have a supervision what is going on in your hospital, and that every head of the department knows if some physicians or some teams come in trouble by a higher frequency. They need more guidance, more support. And after every euthanasia, a post hoc reflection intervention is advised. What is the feeling of everybody? What is the experience? If we have a new case, do we it in the same fashion? Or did we learn something? Or do we have modified our plan? And the requests are coming of all ages, from 20 up to more than 90 years. More men than women. The Catholics, 42%. The atheist, agnost, 44%. Islam, the Jewish people are absent. I have atheist people that say, in every case, not euthanasia. And I have seen Catholic persons who were against the law, but when they become sick, are saying, it's unbearable for me. No, I like to ask you euthanasia. So we can't say that it is purely defined, separated by religion, except for the Islamitic and Jewish people. Okay, what is the reason? 41% for physical suffering, 14% for mental exhaustion, a quarter, 24%, psychological existential suffering, 12% the fear of future suffering. That is already an extension of the criteria of the law. In the law is stipulated there must be unbearable pain, unbearable suffering. Here is fear for future suffering. And some say, but the fear for future suffering is already an unbearable psychological suffering. And so we see that this is one of the elements of the slippery slope. Mostly 2 or 3 reasons. It is not just physical, just psychological, it is a mixture. And what we see is, with more than 100 cases that we analyzed, only in a third, 37%, came to a euthanasia procedure, because 9% have a lack of legal criteria. Although the caring team said this is a request in accordance to the law. 14%, the patient start caring because was not informed about the possibilities of palliative care. And after the dialogue with the palliative team, 25% of the patients withdraw the request. So again, this proves that the palliative filter is very important to separate the real euthanasia request from the requests that are in fact a cry for help. Don't let me alone in this situation. Please help me. And you see, 2/3 of the request is not ending in a procedure. Maybe is that the reason why there is a difference in the public of 2.5% in our hospital with the obligation of the palliative filter that we have only 1%. How do people behave after such an euthanasia? It's amazing. the patient, the family, and the care team have a very huge degree of peace of mind. Very rarely is the family afterwards divided, that somebody said it's done too early. Mostly it is okay for everybody. But what about the physicians? Some physicians explore the request, inform the patient, the family about palliative care, about palliative sedation to relieve the suffering. But if the patient persists in his request, can move to euthanasia if symptom control is still ineffective and the patient refuses palliative sedation. And if it is in harmony and in a consensus, you have just seen there is peace of mind, and then it is possible that also the euthanasia is a good act. But some physicians, for personal reasons, will never perform euthanasia. And what can they do? They send the patient to a colleague in the department who will perform the euthanasia. And we have one department that said, in the beginning, we will never do euthanasia. But then there came such a blame on that word that the head of the department said, is there somebody in the group of the physicians who is able to do it? And two persons say, yes, we will help our colleagues in difficulties, and we do it as a technical act without any personal relationship to the patient or the family. A technique, it's up to our convention, not the ideal. Some others send the patient to a colleague in the department who always end up with deep, continuous palliative sedation, even if the legal criteria for euthanasia are present. And then there's no euthanasia, but many family members and healthcare professionals are in trouble, have moral distress. Or some colleagues say that euthanasia is not done in this hospital and send the patient home to another hospital, while the legal criteria are okay and everybody is in distress. Also a problem. Some physicians decided never to do a procedure and can be confronted with a difficult dilemma. Why? The feeling to abandon the suffering patient after sometimes a very long trajectory. If they perform the procedure, they have overruled their personal conscience. And then they have a personal moral dilemma. And if they refuse the euthanasia, then is there a moral distress not helping the patient? Or there is the verbal threatening of the family to blame you as a physician in the media, to blame the hospital, to blame the church. Or no personal problem for the physician if the legal criteria are not fulfilled, although the family asked the physician strongly to ignore the law. Here is suffering, you have to do something. Ignore the law and violate the law. And nobody has structural support for the physicians. Some physicians don't like explicitly to say, I have a problem. And these physicians are at risk for burnout and sometimes leave the discipline of palliative care. So we lack structural support for these physicians. In the public, end-of-life decisions is automatically euthanasia. Palliative care is not known. Euthanasia is more and more accepted in the general public as a right. It is not a right, in fact. And while the public is in favor for euthanasia, even for dementia, the physicians are very reluctant, especially for psychological suffering. The slippery slope is there, because non-physical suffering is also accepted. The fear of future suffering. The euthanasia came also in an act for minors. The validity of advanced directives was valid for 5 years and now for an undefined period. If the physician refused to euthanize, he has now the moral duty to refer. That's new. And hospitals can no longer negotiate with their physicians not to perform euthanasia. Conclusion, after expert palliative care, about 1 or 2% of the patients are left with symptoms that are not sufficiently controlled. And there we have a need for palliative sedation. And in countries where there is an act, some patients will prefer euthanasia, and we have to live with that. And the Euthanasia Act creates for some physicians moral dilemmas. And these conscient physicians have the risk of burnout and can change their lives. I thank you.
Thank you very much for these two talks. Very, very important. There would be a lot of questions. I think that at the end, the speakers must choose some of the many questions there are, and there we told them to answer thereafter by email for the question that are not able to answer. So from Belgium to Canada, and we listen to the Most Reverend Noël Simard, that is Bishop of Valleyfield and ordinary member of the Pontifical Academy of Life. Most Reverend.
Good afternoon. Buonasera. First of all, I want to thank Monsieur Paglia, Monsieur Pegoraro, and all the Pontifical Academy for Life staff for having organized this important international lab on palliative care and giving me the opportunity to make this presentation on palliative care and MAID, or medical aid in dying, in Canada. My presentation is structured as follows. After a short introduction, I will present, the development of euthanasia and assisted suicide in Canada towards a greater access and acceptance. And after, I will present, the palliative care situation in Canada, and following, the efforts and actions made for the promotion of palliative care in Canada, I will present, the challenges and the threat posed to palliative, that MAID pose to palliative care in Canada, and finish with a conclusion. As introduction, I have to say that, in Canada, there is a greater acceptance of euthanasia and assisted suicide, the so-called MAID, or medical aid or assistance in dying. And I think this development of euthanasia, the acceptance, is based on a strategy, based on a confusion of language. It is a care, no more an act of killing, and it's based also on the confusion of the legal and moral dimensions. It is legal, so it's morally justified. The development of euthanasia and assisted suicide in Canada towards a greater access and acceptance. And I think, one case which started, the development is the Sue Rodriguez case in 1993. Affected with the Lou Gehrig's disease, Mrs. Rodriguez asked that when she had judged that it was the time, she could be assisted to commit suicide. The Supreme Court of Canada said no in holding the prohibition of the Canadian Criminal Code. But Mrs. Rodriguez was helped to commit suicide by a physician. But this physician, nobody knows who he was, but he was not sued. Some years after, on June 2014, the provincial government of Quebec enacted Bill 52, which authorized a physician to provoke the death of a patient who is asking for and who is seriously ill and in terminal phase. And in order to override the criminal code, the provincial government of Quebec established that the assisted euthanasia by a physician was a care and as such was under the jurisdiction of Quebec. And this Bill 52 comes into force in December 2015 and set up the rules for the MAID, as well as giving indication for palliative care and advanced directives, which does not include requests for MAID. In 2015, Kay Carter, a woman suffering from degenerative spinal stenosis, and Gloria Taylor, a woman suffering from amyotrophic lateral sclerosis, brought a civil claim before the British Columbia Supreme Court, challenging the constitutionality of the Criminal Code provisions against assisted suicide and euthanasia. And they focus their case, however, on Section 241, which prohibits aiding another person to commit suicide. They succeeded at trial, but the majority of the Court of Appeal allowed the Attorney General of Canada's appeal. Kay Carter and Gloria Taylor had obliged the Supreme Court to rule, to make a decision. And on February 2015, the Supreme Court, in an anonymous decision, ruled out that Section 241 and Section 14 of the Criminal Code were void insofar as they prohibited physician-assisted death for a competent adult person who clearly consented to the termination of life and had a grievous and irremediable medical condition that causes enduring and intolerable suffering. And following the ruling of the Supreme Court of Canada, and after a lengthy delay, the House of Commons passed a bill, C-14, allowing for doctor-assisted suicide in the case of a terminal illness. The Senate amended the bill, expanding the right to die, but finally, a majority of the Senate agreed with the wording provided by the House of Commons, indicating that only patients suffering from incurable illness whose natural death is reasonably foreseeable are eligible for a medically assisted death. So Bill 52 in Quebec gave patients the right to MAID, but Bill C-14 aims to protect, the physicians and the nursing staff who perform euthanasia, protect them from criminal suing. So it was more focused on impeding physicians to be sued by the law. On June 2017, Jean Trichon from Quebec, who had cerebral palsy, and Miss Nicole Gladue, a 74-year-old woman living with a post-polio syndrome, challenged both Quebec and Canada's MAID legislation, arguing that the laws were too restrictive and violating their charter rights. Quebec Superior Court Justice Christine Baudouin found on September 2019 that reasonably foreseeable and end-of-life provisions were an infringement on the life, liberty, and security of the person under the Charter of Rights and Freedoms. Justice Baudouin struck them down and asked the federal and Quebec government to change their laws. These two governments did not appeal the decisions. But later on, the Quebec government ruled that the eligibility criterion end of life was no longer in effect in Quebec as of March 11, 2020. On March 2021, the federal Bill C-7 was enacted, which no more requires that death be reasonably foreseeable. And the Senate approved euthanasia for people with mental illness and gave 18 months to the government, the Canadian government, to establish rules on MAID for people whose only medical problem is a mental disorder. On March 2021, the Parliament of Quebec created a special commission on the evolution of the law on end-of-life care, with the mandate to study the expansion of MAID for people with disability and those whose only medical problem is a mental disorder, as well as the question of advance directive. On December 8, 2021, the Commission presented its report, which includes 11 recommendations. Among these, the Commission says yes to MAID for people with disability, as those with advanced stage of Alzheimer, but no for people whose medical problem is only a mental disorder. In conclusion of this survey, even though provincial and federal governments had promised safeguards to avoid abuses and to protect the most vulnerable members of our society, there is a clear side slip which gives a greater access to euthanasia and threatens more and more the sanctity of life and the inherent dignity of the human person. And now, what is the situation of palliative care in Canada in that context? First of all, I have to say there are some political and actions to promote palliative care. The Canadian civil leaders have always declared that the legalization of the medically assisted suicide and MAID was not an action against the development of palliative care. They promised to support a quality palliative care at home, in hospital, and in palliative care facilities or hospices. On December 2017, the Canadian government passed the bill, or the Act, Bill C-277, an act providing for the development of a framework on palliative care. And in 2018, arising from this bill, the Canadian Minister of Health proceeded to a large consultation on palliative care in Canada. And in 2018, the Canadian Institute for Health Information, funded by the Canadian government, launched its 69-page report entitled Access to Palliative Care in Canada. And in the conclusion, we read the following an important sentence, and I quote, "Estimates suggest that up to 89% of people might have benefited from palliative care. However, a substantial proportion of Canadians were neither identified as having palliative needs, nor as having received palliative care in their last year of life. Almost all provinces and Canadian territories have plans and strategies to promote good palliative care and equitable access. And in 2001, Pallium Canada was created, which is a national and pan-Canadian non-for-profit organizations that aims to improve palliative care across Canada through community building and education of health professionals and carers. The government did good actions and efforts, but also the Catholic Church. On September 2014, the Canadian Conference of Catholic Bishops launched a life-giving love, which is a national campaign for palliative care and home care and against euthanasia and assisted suicides. On December 2015, the Assembly of Bishops of Quebec published To Approach Death with Christ, a pastoral letter on death and dying, and a 5-step reflection on end-of-life care in light of the Word of God. In 2017, at the request of Catholic Health Alliance of Canada, the Covenant Health Palliative Institute produced a scan which consists of a comprehensive inventory of facilities, palliative care services, and innovative practice within the Catholic healthcare system. On July 2018, the Canadian Conference of Catholic Bishops presented a report as a contribution to the large Health Canada's consultation on palliative care. In their report, they reaffirmed that palliative care cannot be considered only as a healthcare service, but as the most humane movement and response to the needs of seriously ill and dying persons. And also that palliative care cannot include the so-called MAID, which is totally opposed to good quality palliative care. On December 2020, the Executive Committee members of the CCCB sent a response to the recent legislative decisions relative to Bill C-7. They expressed their serious concerns about the elimination of the foreseeable death or foreseeability of natural death criterion and the expansion of MAID, which will have grave implications for aging and vulnerable Canadians as well as for the healthcare system. And on November 2021, Bishop Christian Rodambourg, President of the Assembly of Bishops of Quebec, sent a letter to all members of the Quebec Special Commission on the evolution of the law on end-of-life care. And in this letter, he expressed not only the serious concerns of all bishops, but also their opposition to the expansion of MAID. He invited all Catholic and people of goodwill to focus on quality palliative care, the only alternative to MAID. And finally, on November 2020, after 3 years of intense work and in collaboration with 6 other partners, the ad hoc Committee on Palliative Care of the CCCB launched Horizon of Hope, a resource kit on palliative care and end-of-life issues for Catholic parishes. This kit comprises 4 modules, and it addresses questions surrounding palliative care, dying, death, suffering, and bereavement in a holistic fashion through theology, medical expertise, and the compassionate community model. MAID is posing and giving some challenges to palliative care promotions and pose some threats. And I will just give some example. When Bill 52 was enacted in Quebec in 2015, the then 29 existing palliative care hospices in Quebec refused to offer MAID. But because of the threat made by the government to reduce their funding, 17 out of 29 now offer it. Another example, after the Supreme Court decisions and the enactment of Bill C-7, many groups and organizations, Catholic and non-Catholic, like Living with Dignity, the Euthanasia Prevention Coalition, the collective of physicians against euthanasia. These groups promise to continue to fight for the protection of the most vulnerable members of the society and the recognition of their dignity until natural death occurs. They also promise to defend the right of physicians and nursing staff to refuse to perform MAID. But these groups opposed to euthanasia are struggling and facing financial problems. For instance, the organization Dying with Dignity, which promotes euthanasia and assisted suicide, is recognized as a charitable organization by the federal government, and as such is able to give, receipts as income tax deductions. But Living with Dignity and other organizations which is opposed to euthanasia, to MAID, and the expansion of the access to MAID was not recognized as a charitable organization. So there is threat to the development of palliative care. So in spite of all efforts and promise of government, because of the clear support of media and political leaders in favor of MAID and its expansion, there is a lack of real commitment in expanding palliative care in all settings and in offering a true and sufficient financial support. No wonder that dying people may feel pressure to ask for euthanasia and assisted suicide when quality palliative care are not largely accessible. So, as a conclusion, I think it seems that the more the access to euthanasia and assisted suicide is expanded, the less palliative care is sustained. It is more and more difficult to reverse the present Canadian tendency in favor of MAID and the expansion of its access. In general, the population and even Catholic peoples support the strategy promoting MAID. Strategy, as I mentioned at the beginning, Strategy based on the support on the quasi-absolute autonomy of the person. It is a personal choice, it is my right. Strategy based on the confusion in the language. It's a medical care and no more an act of killing. It is a strategy based on the confusion of legal and moral dimensions. It is legally permitted, so it is morally justified. So one of our challenges is to find ways to promote true respect for life, love, compassion, and meaning to life. And I just want to give the final word to a lady who spoke in an article on palliative care, and I quote her. Maryse is a lady who became quadriplegic after a 2016 car accident. And she wrote, I am in favor of a better access to quality palliative care, which offers a real relief to pain and a psycho-spiritual support not only to the suffering person, but also to the family and nursing staff. I encourage everybody to choose to live with dignity until natural death occurs, instead of dying with dignity in choosing the time and the means. Thank you very much.
Thank you very much, Bishop Simard, for this talk. And we see that there are many, many questions to this area, and many are upset because we learn now that it's difficult to resist to that pride stream of movement in favor of euthanasia and assisted suicide. We learned it from Leuven, and now we hear it from Canada. And Dr. Talona has sent the questions to the speakers, and we would ask them to answer them and to comment on them by reading it. First, we should start with Professor Gastmans.
Okay, good evening. I got many questions, and one of them, the first one was, what is the legal foundation of the extra requirements that we implemented in our hospital? Or what is the legal foundation of the palliative filter? Well, essentially, there is no legal foundation of the palliative filter. It are extra legal, professional requirements that we implemented in the hospitals and the nursing homes. So it is some kind of as a professional agreement that is taken in particular institutions to apply these extra requirements. Yeah.
So, Professor Gastmans, perhaps choose another question. We have a time limit so that the other speakers also can answer two questions. I'm aware that there will be a big discussion after that, and we have to continue with these debates, how to resist and how to react on this movement. We're all sitting here together and online worldwide, but now we have to limit the discussion to altogether now 5 more questions. One to Professor Gastmans.
Yeah, another question is about written ethics policies. What we also see in Belgium is that these written ethics policies were mostly developed from the moment on that Euthanasia Act was approved or came into force. But it is much better, of course, to start with developing written ethics policies on all medical decisions at the end of life before you have a Euthanasia Act. So you should prepare in a certain way a good end of life care in your country, in your hospitals and nursing homes. And a way to do that is to prepare written ethics policies on pain treatment, on palliative sedation, on withholding, withdrawing, life-sustaining treatment, etc., etc. Because otherwise there is too much focus on euthanasia, and the other medical decisions at the end of life are forgotten. And that is what should be prevented or avoided, I think.
Thank you, Professor Gastmans. Then we should move to Professor Menten with 2 questions presented to him.
One question is that there is no difference between euthanasia and palliative sedation, according to anesthesiologists, but there is. If you do euthanasia, you kill the patient. If you do palliative sedation, you let them die. There is a huge difference for the physician. And let them die is part, with relief of the symptoms, is part of palliative care. Euthanasia is, up to my opinion, non-normal medical act outside palliative care. So killing or let them die is a difference.
One more question.
What is the moral responsibility in collaborating and referring to another physician? Well, for some physicians, is referring the patient to a colleague who will perform the euthanasia procedure, then he is some way involved in referring and is in some way collaborating in the euthanasia procedure. And for some physicians, is that a moral problem? Others will say, I refer the patient and it's not my job anymore. But if I refer the patient with the aim to kill the patient, some physicians have a problem with that.
Now we should move to... No question. Then I have a question to you, Bishop Noël. There are reports from Canada that the assistant dying, the maid, is connected to organ transplant. Physicians have reported on that in New England Journal of Medicine. So they give this act, assistance in dying, an act of altruism because people are donating their organs after it. Can you comment on that?
Yes, it is, a little bit problematic because, there can be pressure on people, to ask for euthanasia in order to be organ donors. But, the dimension of the voluntary action, because, Canada asks, for the consent of the person. But you see how, in the case of the people with a mental disorder, the problem of consent is becoming more and more complex. And I think we have to be very careful when we use the concept of compassion or solidarity with people. When I was, I with another bishop, I went to a commission organized by the government of Quebec for about the implementation of a new bill on euthanasia. The minister was in charge, told us, the 2 bishops, we are working both out of compassion. That euthanasia is made out of compassion because people don't want to suffer. But, suffering is not, it's not only physical. We have to be very careful not to reduce suffering to physical pain. But there is all the moral, the, social and also spiritual suffering that, the pain relief cannot ease. So it is very important to not to use or to use compassion with a clear meaning, which is to accompany, people and with also the desire not to abandon them, but to accompany them until natural death occurs. And so I just want to finish with, an example. One day I met my physician, and he told me, he said, last week I went to the hospital and I had one of my patients, he was on sedation, a semi-coma, and he woke up, and so he asked for euthanasia, for medical aid in dying, the so-called. And so he said, I sat with him and I explained to him, do you know what you are asking for? He said, I just want not to suffer. She said, did you suffer when you were in the semi-coma? No. So he said, because, the euthanasia is you terminate your life. You put an end to your life. He said, it does not, I don't want to kill myself. He said, and I don't want to ask you to perform an act which is contrary to your medical practice. And so he said, okay, so he said, I will put you back I will give you back in a sedation. But meanwhile, do you want to see somebody of the family? He said, with my grandson. And there was a reconciliation. They wait for the grandson to come to the hospital. There was a reconciliation. And, you see that accompaniment. For sure that there are so many questions, like, for Catholic ministers who are asked, to go to the facility to give, the sacrament of the sick to some people who are asked, for euthanasia, the question of the funerals, how to accompany until the end without, saying that we agree with, what they have done. So you see that it's posing many complex issues to our pastoral work also, and not only to palliative care.
So thank you very much. At the end of this afternoon, I would like to thank all the speakers for this very, very important afternoon. And my co-chair, Professor Sahm, thank you very much. Just two things. One thing is that tomorrow, who is interested, we will focus on the real progressive palliative sedation for refractory symptoms and for the real definition of palliative sedation. And I would like to take from Professor Gastmans the conclusions. We are looking at the normalization of euthanasia, but we are a critical voice, a permanent critical voice in a constructive way, in a constructive stories with the real palliative care, the original palliative care. I thank you everybody very much, and I pass to Monsignor Pegoraro to conclude.
Only many thanks to all participants online and in presence, and special greetings and thanks to the speakers online and in presence for this very interesting afternoon. And I hope it was very useful to have this view from different countries, different experience, how we can learn each other to prevent some trends. Many thanks to the two chairs, very good job, and all the staff of the Academy for the support of the event. See you tomorrow afternoon. Many thanks.